We're ready to go?
We'll give it a couple more minutes. I don't think we're just opening it up to people now. So welcome to the people who are just logging in now to the Drug and Alcohol Research and Innovation Active Learning. We're running a little early today, which is nice. And we have our speaker and everything else at the ready, but we'll just give everybody a couple more minutes before we start off in earnest. I hope everybody had or enjoyed the symposium last week, the NCCRED symposium, if you were there in person or just there virtually. There was a lot of interesting presentations, and we're back on this week. So hopefully, hopefully everyone enjoyed that as well. We'll just give it another minute or two before we start in properly. Well, I think we look like we have reached a quorum, and we've ticked past 2:30 now by my watch. So firstly, I'd like to welcome everybody to the Drug and Alcohol Research and Innovation Active Learning. Daria, again, to those who were in Canberra last week, hope that was enjoyable. This week we are back and we've got Adele, Sheridan, Magro. And Adele is an accredited mental health social worker and the manager of the Domestic and Family Violence Service at St Vincent's Hospital here in Sydney. And she has extensive experience in health, providing management, mentoring and leadership in the area of women and child health, and has also worked in the NGO sector as a specialist domestic violence counsellor, educator and trainer and service coordinator, and so is very qualified to be presenting today on situational counselling for domestic violence disclosure. And just so everybody online is aware, Adele will be prompting us to move her slides along. So in case you hear that and you're wondering what that is, she's going to be prompting us for that. But without any further ado, Adele, thanks very much for joining us, and I'll let you take the reins.
Thank you, Chris. Look, it's hello everyone. I just wish I could see you all in person, but it's a real privilege. It was a privilege when I got this invitation to present here today. So it's just that's my first acknowledgement, I guess. I feel very privileged to be able to share with you today. And there'll be questions after, of course, but the other huge privilege I've got is being employed by St Vincent's Health Network Sydney as their manager of their Domestic and Family Violence Service. And I'm open to any questions about that position as well. So, yeah, I'm Adele Sheridan Magro. Can we go to the next slide, please, Arlene? Thank you. I very much want to acknowledge country and absolutely pay my respect to Aboriginal people, past, present, and emerging, and their leaders. They have looked after this land for 60,000 plus years. So they know a lot about this country and this land that we all have the privilege of working on, playing on, and just living on. I myself and today am coming from Gadigal land of the Eora Nation. I happen to literally live and have for a long time, work and play on this land, which is the land, Sydney, the inner west Tadangas of Sydney, the Gadigal lands. But I also, when I always do acknowledgement to country, I want to make it more real, both for myself and to acknowledge any Aboriginal people attending this meeting today. And my own cultural background and heritage is Irish. I'm a proud Irish Celtic woman. And I want to exchange an acknowledgement for those Aboriginal people here today. And I'm going to give two words from the Gaelic nation. And one is Anan, which means spirit, soul, if you will, and then Kara, which means friend. And in our tradition, if you put those two words together, they mean a spiritual friend beyond time, both past and present. So that's my acknowledgement and my gift and wishes for you today. So next slide, please. Okay, so we know the title, Situation, Counselling and Domestic Violence. So I'm certainly not going to be, sitting here telling you this is what domestic violence is and going through all the, the descriptions, because we know it's all interrelational. But just so we get our head around, I suppose, what New South Wales Health, because I'm assuming a lot of us work for New South Wales Health. There is a policy that you most probably come across, but what the New South Wales Health policy is telling this thing we call domestic violence is this is theirs. It's a violent, abusive or intimidating behaviour carried out by an adult person or partner or former partner to control and dominate that person. And you can read there, domestic violence causes fear, physical and also psychological harm. It is most often violent and abusive or intimidating behaviour by a man against a woman. Now, let me be just up front and very clear here. In my service, I see male victims of intimate partner violence, but overwhelmingly and predominantly, it's a same-sex intimate partner. So it's male to male violence and abuse. But we know that all research statistics clearly show us that up to 93 to 95% of all violent intimate partner violence is perpetrated by a man against a woman. So I will be referring to women, but please know that I'm critically aware men are perpetrated on in a domestic setting, usually by a former partner or ex-partner of the woman they're in a relationship with, or family violence with brother, father, right? So, all right. So living with domestic violence has a profound effect upon children and young people and constitutes a form of child abuse. So that's what New South Wales is telling us. That's what we are responding to. That's what we're being asked to provide counselling in a situational context for. Next slide, please, Arlene. But I want to, and you'll see me do this a lot through this slide, I want to get beyond the rhetoric of what it is. And if I could capture it and say to you, this is what I believe it is the atrocity of one human being against another human being. It's an absolute atrocity. Next slide, please. And I think for us here, what is absolutely vital for all of health is to know, I mean, this is just one research from Vic Health. There's the World Health Organization, who's a multi-country study that has found exactly this, right? That the leading cause of mortality, morbidity for women of childbearing years 16 to 45 is the impact of violence and abuse. So it is a more preventable ill health and premature death. And this happens to be Victorian women, but we know this absolutely concurs with all other research and research from the World Health Organization. So what's this mean in reality? A woman is far more likely to die or be permanently disabled physically, mentally, through the impact of violence and abuse. So beyond what this is telling us, we have to hold central that it is an absolute health issue for women and our society. It's a gendered issue, a social justice issue, a health issue. Next slide, please. But again, what I think for us to kind of grapple with here is the human loss of what really living in with what we, is termed domestic violence, but what I see is profound, complex trauma. It has been equated to living in a war zone or being involved in a natural disaster, such as a fire and earthquake. And the reference here is it's quite a famous book. It's like almost, dare I say, a Bible for those who work with complex trauma. It's Dr. Judith Herman, and she wrote this literally in the 90s. But it has stood a test of time. And I think that is an image and a knowing and awareness to have that it is like we've lived in a war zone. And people constantly ask me, well, Adele, what's the difference? And that's the difference. Women have said to me, women that, I've had throughout the years, the absolute privilege and honor to work with predominantly women, now some men, who have shared their experiences of the impacts of violence, abuse on them, and that they don't use the medical words we use, like trauma. They said it's like living with in a war zone, like I've been to war, I've had to survive, like walking on broken glass. So I think it's this language and this emotion we need to get before we can walk into the situational. Okay, next slide, please. Thank you. So, and one of the other things that is very much asked, well, why doesn't she leave? If I had a dollar for every time that was asked me, but we rarely do we say, well, why doesn't he stop? And why, as a society, we can't make him stop. But this is a thing that I think we need to hold central when we are, entering a space, which we'll talk about shortly, where there's been a disclosure of intimate partner violence. And this is a brilliant, and it's one of those stellar researchers. It's called the Keys-Young report. And there's been many reports since then, but they all state this, that shame is a major factor in inhibiting women from disclosing about domestic violence or seeking help. So when we put this together, when we put this atrocity, this war zone, and then this sense of horrific shame, That's what we need to hold central. That is what I've called beyond the rhetoric of the language of domestic violence. Next slide, please. So what I'm terming, what I want you to critically maybe think about here, so with that knowledge is, so the space we enter is a space of complex and multi-layered trauma, which can and may be intergenerational and transgenerational. All right. And I think that's very powerful because it goes beyond the language of domestic violence. Because for those who know me, I've said it many times, I really don't even like the term domestic violence, because let's be upfront here, it just describes where it takes place, not really what it is. I mean, domestic, So we were being asked to enter a space of shame, a space where the other has lived in that metaphorical and experience as a war zone, a space of profound risk to the other's safety. We know there's absolute risk and safety issues. And this is vital. We're being asked as clinicians, and this is in the drug health setting, the drug and alcohol settings, a space of intersectionality. Intersectionality, where sexuality, gender, culture, ethnicity, religion, age, history is entering the room as well. Next slide, please. So we're entering a space of double listening, right? And, this is very much, if those, you may well know of this therapeutic theory, it's called narrative therapy, narrative approach, right? And one of the gurus of that was Michael White. He was, the narrative father, if you will. And he first brought it to my attention when I had the absolute honor of being trained by him, when he talked about this notion of double listening. And again, this is going beyond what a worker should or can do. It's this acknowledgement that we are actually, when we enter the space of talking to a client, patient, whatever, counselling, of double listening. So the double listening about abuse and trauma, i.e. the complex psychosocial issues, arbitrarily resonates with our own experience and history. And where do we ever see that in, your health employee? The way we need to know that that's what we're doing. So workers' distress indicates that certain values, wishes and hopes that professional have about the world and themselves will be inevitably transgressed in some way. So if there's an inevitability, I know there's other ways of viewing it, like burnout and vicarious trauma, but I particularly wanted to bring this to you guys because I know that you're double listening constantly about all types of psychosocial stressors, psychosocial, disclosures. So Michael White further asked, are our own experiences then silence? We have to put up the professional lens, the barriers, the boundaries, right? So he's asked, are we being silent similar to the way in which an abused woman is silenced? Michael White asked that. Next slide, please. But I asked Michael White, I said, so we're in the therapeutic space. is it seen, understood, and embodied that the work of healing, call it counselling, is a most courageous act for both people in the therapeutic relationship and space. So again, I want you to critically think that what you're entering, given what we've said is that space you're entering, you are being courageous, and it takes courage, and that must be acknowledged. So I want you to stop here for a second, right, and just think about the last time a person disclosed to you that they were being or had been impacted by violence and abuse, and the courage it took you to listen and to remain in that space. Next slide, please. So responding. So here's the standard, what you'll get in health, the standard kind of thing. And look, vital. So you would, if you were responding, you would stress the violence is not a fault, and vitally not the woman's responsibility to stop that violence, because it's not. You would explore options around safety, options about, well, what do you want to do? Right? You would decide on a mutually agreed plan of action, which is safety planning. You'd refer the woman and the children accordingly. But let me just give you a little insight here. We have this thing in health, certainly the health sectors I've worked in. I've worked in 3 large LHDs, that referrals will save the day. Well, they don't, right? If a woman has disclosed to you, for whatever reason, you must have given off that energy, call it what you will, or being willing to enter that space where she felt something safe to do so. So the immediate referral on, we can talk about that in questions, may not be what is absolutely needed there. So we'll talk about that later. So acknowledge and validate her fears. Okay, reduce anxiety. These are all the tick boxing that, you know, good practice says you would do. Next slide, please. So responding. So absolutely you stress the need for a woman and her children to be safe. Okay. You do need to consider the needs of the children in their own right. You need to be aware of cultural factors, be clear about confidentiality, and ensure you let the woman know honestly about whether information is confidential or not, under what circumstances the information would be divulged. Now, so we don't stop the flow, I want someone to ask me about that later, because that is vital around connection and a sense of safety, but we'll go on. So next slide, please. So on an agency level, okay, I mean, it is right, because you don't work, you know, no work is an island. You know, there should be supports, protocol, pathway, procedures in place. Not that they're going to particularly save or you know, profoundly reduce risk to a woman, but they're going to support you, and that's vital. So there should be policies and procedures, right? You know, there should be and it should be inclusive of cultural factors and address conflict. It should be written, you know. It is important to develop and maintain a list of appropriate referrals and pathway, and, you know, if you can establish and maintain contacts with domestic violence workers and services in your area. It's kind of standard 101. Yes, this is what we would do. Next slide, please. But I want to go again. I want to look critically beyond that. And I want to say, well, really, yeah, we do that. What's the critical questions that would underpin what we're doing? So I provide a lot of training. People say, well, how do you do it, Adele? How do you ask a woman or keep exploring with a woman? And if you take away anything from today, take away this. Critically ask yourself, how would you want to be asked about the impact of violence in your life? Because very, very few of us at some stage wouldn't have been impacted directly, witnessed, or had a very close friend impacted. So how would we want to be asked? We need to really critically, right? So, and we can talk about that if it comes up later in the questions. So both on a personal and professional level, critically know that it is more than simply you that walk in the door. I'm assuming that for the most you work in drug health services, okay? What a discourse of power and knowledge that is walking in behind you. Behind that, the biomedical knowledge, the pharmaceutical knowledge. You don't just walk in as Sue, Adele. You walk in, I walk in, and then I've got my social work in front of me and all the history that has got. Imagine I'm saying to an Indigenous Aboriginal woman, and I'm a social worker. No, just more than me walks in the door. Yeah. So whilst we may have certain expertise, we will never be an expert in or of another person's life, values, or history. You will never be an expert. We know, I say to people, you may know a slither, a fine slither of that person's life. So more than a victim awaits you, absolutely. Rather a person just like yourself. You're multi-layered, you're complex, you have an abase of life experience and history. Okay, next slide, please. So I really like this, and I got this recently, this image from Education Centre Against Violence, New South Wales Health, because I love, if you do anything about this responding, listen with intent. As I said, how you would like to be listened to. So it's the senses, because what we know, and that's why cognitive approaches to complex trauma really don't work in the long term, because trauma is lives within the body, right? So it's not a cognitive process. Okay, so and that's why you need a far more holistic way of intervening and being present in the presence of complex trauma. So if your lens is domestic violence, even worse still, reduced to the acronym DV without the true knowing, and that what you are entering is a space of profound, complex trauma that is more than situational. It could have gone back from intergenerational, transgeneration, utero, infancy, childhood, adolescence, adulthood. What part of that trauma are we going? I see women, I was saying this the other day at a health meeting, and the correlation between women in intimate partner violence, family, that have also experienced sexual violence is staggering. I mean, so whilst in health, and we know we do that, don't we? We have drug health services, mental health, domestic violence services, sexual assault. That's a systems separation. The human person, the human experience, the lived experience doesn't separate all that. And we do for control. So with intent, listen with intent, with your body, your face, your focus on the speaker. Listen with your heart. Yeah, let's mention that word, heart, right? Practice compassion. Ears, listen thoughtfully to the self and other. What's happening for you in this space as well. So all this is, it's got a duality of self and other. With your eyes, watch and observe, they're not called the windows of the soul for nothing, okay? With your mouth, basic but vital, reflect back words and emotions. That's one of your most powerful tools to speak the language and the metaphors that are being given to you. Give back. Next slide, please. So other knowing. I mean, this is maybe if you've gone past the situation and you are working with someone who wants to stay with you if they're able to, and so they should. So other knowing, I just love this, knowing that where there is sorrow and pain, there's holy ground for that person. I said to a woman the other day, when we're looking at growth, from rising like a phoenix from the ashes of the experience of violence and abuse, she said to me, well, what's the best fertilizer in the world, Adele? And I, and she comes straight out. So forgive me if you don't like this word, shit. She said, shit, and my life's been shit, but it's the best fertilizer in the world. So knowing stuff like that. So we talked about the shit in her life. We used her words, her metaphor. So the goal of therapy and intervention is not closure. No, not a chance. Is to live with the suffering, right? That's why it's not about a process, go through. No, it's insulting. That experience, that violation, that atrocities occurred, they can't just go away. Yeah. So a sense of hope, right? Redefine injustice. Sometimes it just doesn't happen. It just doesn't happen. It doesn't happen in the courts. It doesn't happen with the police. They get it wrong. And that needs to be acknowledged. Your own and tapping into a person's sense of spirituality, universal beliefs, to unpack what's their sense of honesty and justice and fairness. So a space for freedom for a woman to tell a story rather than prescriptions. Imagine options, artwork, conversation. There's a lot of grief work in domestic violence. It's what we call disenfranchised grief, when a person hasn't got a right, a social right to state her grief and a loss of that relationship. It's how many times have we heard when women have said, I'm one of the lucky ones that I got out. There's very little acknowledgement of the shocking loss and grief that relationship once was and held for her. She didn't want the relationship to stop, maybe. She just wanted the violence. So patience and humour. Tell you can't beat that humour. Next slide, please. So, because and this is, I suppose, a most critical challenge for you, because if we don't get real and authentic and hold this knowledge, the consequences can be devastating. So we work within a biomedical model. If we work in health, we are absolutely kidding ourselves if we think we don't, and you would experience it every day. But the practices within the biomedical model of care in health actually can sever, don't you love that word, sever, the link between abuse and emotional distress. So an example of that, you see notes, patient, let's just use that one, patient, currently experiencing, acute depression, chronic depression, major depression, anxiety. So another way to see that is that depression, a profound sadness of the past, right? And anxiety, horrific fear for the future. So why wouldn't you be depressed or anxious or over emotional? But let's name it for what it is. Let's not medicalize it, because the slippage between acknowledging and intervening in the private pain created by violence and then reconstructing this as an individual pathology, you're depressed, you're anxious, is a label away. And it's a medical label often. All the medical labels, borderline personality, in brackets, complex trauma history, they're labels away. All right. So that's I've in the reference list, that comes from a stunning research, and it was called symptoms of, you call it mental health, I call it symptoms of abuse. Stunning article. Next one, please. So, and I suppose when you peel back the layers, and the big buzzword in health is trauma informed, right? Okay. Well, some of us, we know it's written everywhere and it's everywhere, but how much of it's truly happening, is up for debate, I suppose. But there is a lens here that I'd invite yourself to share and to hold and become part of the clinicians you are. And that, yes, I'm trauma informed, but I'm also violence informed. See the difference? Because you need both those lenses if you're entering this space. So a shift in language to hold both trauma and violence informed principles and associated practices. They're very different. See, trauma can be defined as an experience and response to overwhelming negative experience, including interpersonal violence and abuse. So walked into the interpersonal is not intimate partner. So walked into a bank, if they've got any banks out there anymore, the hold up, major shocking horrific accident that you witness. They're different. Yeah. So the reason why you need both, because trauma cannot be held as both cause and effect. That's vital, right? The cause was the violence, the effect is the trauma. Right? So it brings into focus the acts of violence and the impact on victims. Well, this is what we've just said, which distinguishes their experiences and responses from others who experience trauma. Okay, so we're repeating here, but increase attention to the occurrences of and the responses to violence. Yeah. So next slide, please. So I want to, we can read this together, you can read it in your mind, but I've had clinicians, and I've thought it myself, I'm just one worker, right? You know, how can I make a difference? And this is a poem, and I just love it because it really captures that notion of one. You know, I'm just one worker. How can I, you know? So let's read this together. One look defines existence. One word can change a life. One breath can be the end. One move is an ultimate sacrifice. One act can change the future. One mistake could be fatal. One dream could wake you up. One decision cause the inevitable. One truth could create a lie. One death gives rebirth. One love might change the world. One day spins the earth. And that's by Sheridan Brown, that poem. So that's the end of the formal slides and presentation. So I'm really open to any questions that you may have.
Thank you very much, Adele, and some really good insights, especially around language and how important it is. And yes, you know, yes, that dreaded line of why didn't you just leave? I think that retort of well, why doesn't he just stop? So it's a great reminder of just how much victim blaming still
it is, Chris, absolutely
occurs. And I don't think Bettina Arndt's listening, so I don't think you need to tiptoe around the fact that the vast majority of this, and look, I mean, it's not for me, as I'm lucky enough to not be a victim of domestic violence, but you know, I think it's actually almost insulting that we can't say that, and we have to tiptoe around you know, the feelings of the wider male population, because we don't want to be tarnished. It is men, and you know, in the vast part, we need to, if we don't at least acknowledge that, then we've got a long way to go.
Absolutely, Chris.
So please, people, if you've got questions, please put them into the chat. I always have lots of thoughts going through my head. There was a talk a little while ago that I must admit I wasn't able to attend, and it's bothered me ever since that I never got to attend. And it was about how the medical system perhaps in some ways can facilitate you know, domestic violence, and how sometimes you know, the perpetrators can manipulate the medical system and so forth. I just wondered if you had any thoughts and comments around that.
Well, yeah, look, you're absolutely right. And you see, remember what I said, that, and please get it wrong all the time, not just the medical system, when the impact of trauma is on the body, right? So therefore, a perpetrator, and part of his grooming, if to use that language, right, is to groom others, because we know, don't we, that violence and abuse is about power and control. But what underpins all power and control is to isolate, right, to separate. Okay, so if a perpetrator, let's use this language, presents as rational, believable, because he hasn't been traumatized. See, that's the thing. So he articulate, you know, the more insightful, so it seems, the more rational, right? And often
He is a historian.
Of course. And then we're expecting a traumatized woman to be as rational, be as insightful, be as, right? And then in the space of drug and alcohol, of course, you know, you would know this. I know all you good people would, about the control through those substances, the control, you know, through access or denial. You know this. So think of it as there's a beautiful way of understanding that all these tactics, grooming of, professionals, all the other tactics, it's almost like a symphony of dynamics. They all play into each other. And so, yes, and remember, especially in drug and alcohol and mental health, especially, a woman entering those spaces, it's not a neutral experience for that woman. Those spaces will be used against her. You're linked in with drug and alcohol services. You're linked in the mental health team are coming to see you, And so you've got clinicians that, are being groomed. And what the devastating result of this, just to, capture it here, is this. We're making the abuser invisible. We're treating the symptom, not the cause. And when we look, Chris, at a biomedical model, which is presenting problem, diagnosis, medication, treatment plan. The very underpinning framework is that presentation. You present with a problem, we'll diagnose this, and we'll give you a medical treatment plan. Yeah.
No, and just on all of that, I think, well, firstly, yes, I think it's a good opportunity to certainly for people to reflect, on those times where, yes, as you say, the rational partner and those experiences. And I guess it's also a good reminder of, many times we do see patients and there'll be a person around, and this is, where there's no domestic violence occurring, but I think it's still important when you can to try and get those first assessments one-on-one.
For sure.
Because
never ask about any of this with another person present.
No, and but I guess it's also and that way, when the time comes where you really, really want to see a person by yourself, then it's not coming from a place of, because it's this person that you suspect. It's because that's the way you always do it. And that way you can say to that person, well, I always get my history the first time from the person in front of me, and then I get collateral from other people. And that's the way I do it. That's my personal take. Not to tell people how to do their job, but
no. And you find what works for you. I mean, what works for me is, in previous settings in health and women's health, I used to say, look, it's not me, it's the system, the policies here. They make me see a person on their own. I know it sucks, but I've got to do it. It's not personal. You do whatever works. You know what I mean? Yeah. You find your own style and what works. Yeah.
And I guess, because of that issue, and the questions come up as well here on the forum. So, someone I wanted to ask about the issue of confidentiality and disclosure, with the CT. I don't know what with the CT means. I'm a CT. I don't think they're referring to me. With the client, sorry, with the client.
Yeah, okay. So disclosure. So again, no. So this, thank you whoever asked that question, because it is one of the most ethically fraught aspects of around confidential, especially if there's child protection. That's the big one, isn't it? Right. So and it's so challenging because you have to hold both, right? But what I always encourage people to do is, best I talk, you'll understand. So if it's a woman who's disclosed, I will use language that names it for what it is. So I would say, look, no one has a right to do this to you. Absolutely no right. Right. So, and what he's doing, I said this the other day to a woman, what he's doing it is a crime. It is an absolute crime. And I don't want you, and I don't need your permission, but I am going to report his crime. Right? Because that takes it off. I have to call the police. No, that's all. Oh, do you? You know, really talk as if, so you're not reporting him, I am. Right? Same with child protection. Your child and you have a right to be safe. Right? And what he's doing is a crime to you and your child, and he's violently abusing that child. And I am going to report him. Right? Now, when I work longer term with women, I've got many women to make their own helpline report. It's empowering. I'm not suggesting you do that the first time, but it's empowering for a woman to know that she can actually report him. Because what I say to women is DCJ, as we know, want to know that what protective factors are in play, right? How more protective can a woman be than actually reporting him to them and request help? So just name it for what it is. And just one last thing on this, I always say to a woman, I invite a woman's own knowledge into the space. So I will say something like this, and I say it often, you and I both know women and children get murdered by these men, right? And I've never seen a woman who goes, no. And you'll always get a woman going, yeah, they do. I said, you've only got every week you'll hear a woman's been murdered. So you're crediting this woman with knowledge, and you're also giving her a kind of way out of putting the responsibility on her to do something. Yeah. The language is vital.
Is there, I imagine, and from my, as not somebody who manages this as much as yourself, but I guess in my own gut, my instinct is anxiety of risk then conferred to the person in front of me.
Yeah, and that's understandable. And because, but it's that thing of with intention, with, being, say, I've said to a woman, he terrifies me. How this has impacted on you. You see, because you're making it relational. You don't have to, disclose, oh, look, I know I was in a domestic violence relationship 5 years ago. No. It's this woman's story, not yours. Right? Okay. So one of the things I would say was, he sounds horrific and frightening. Yeah. But look, every situation is, you've got to read what's going on. You've got to be present. And like I started the PowerPoint with those few, beyond, the labels, beyond this is domestic violence. Remember, how would you, would you say, a soldier, a veteran, they call them, come back from, I don't even know if they're still there. I don't think they're, in Iraq, in the other place, right, in Afghanistan. How would you enter that space? And yet women have lived in their own private, in their home war zone, where the bomb's going to go off any minute. Would you be saying, you've got to do this, and you've got to do this, and I've got to refer you this, and you've got to do... No. you'd be acknowledging. Oh, that's shocking. See, use real language. That's what I'm saying. I mean, I know, you know, we do anything, Chris, we've got to be real about this, you know, genuine authenticity. Yeah.
Another question's come up.
Yeah.
What advice would you give for supporting someone who has disclosed violence but is pre-contemplative about taking action or addressing substance use if they might be using, you know, to manage their distress?
Yeah.
How do we help them? How do we help these people?
Yeah, look, because the most powerful thing you can do, right, is plant the seeds. It's a cliche, but cliches are cliches because they're true, you know, right? So know and acknowledge it. Say, you might not be ready anywhere near right now, but it doesn't matter. So the worst thing women have fed back to me is once they've said, no, I'm not leaving, or no, I don't want the referral, or no, right? That's it. Like the ship sailed. So what we can do in this space is say, doesn't matter. We're here. Right? It doesn't matter if you want to plan to leave or not, or work towards it, or see how you go, right? We're here. Whether it's this month, next year, we're here. So it's just that massive seed of saying, we're here when you're ready. You know? That's the best thing you can do. Yeah.
Another question's come up. How, and this is I think following on from what I was talking about a moment ago. How can we support women after an incident has been reported? We hear so often about women making reports, and they are later murdered or further assaulted. As you've been saying, these experiences are often not just isolated events, but ones women have lived in for the duration of relationships.
So how can we support them once they have?
After an incident has been reported.
So I just want to get my head around it. So it's a great question, but just make sure I got it right. So the question is, so they've made a disclosure, what, to, or reported to the police, say?
I would assume that's...
Yeah. And then how can we support them?
Mm-hmm.
Well, you know, a very, very keep consistent, and what you've said and what I've just said previously, just say, you know, acknowledge the massive, because one thing we don't use is, let me just say, one thing we don't kind of get hold of is this notion of courage and what it took to do that. And that's what I was talking about, that other ways of working, when, you know, a woman may or may not get any sense of justice from that, may bitterly regret doing that, and the real realization it can actually increase risk to this woman. Because we know, don't we, that when a woman attempts to leave or has just left, she's more at risk, right? So that is really working with her around her risk and safety planning. And look, if she's made a report, you know, we're talking systems here, the police would have linked her into what they call WDV CAS, which is the Women's Court Advocacy Domestic Violence Scheme. So she does need to be linked in, because her risk, and this has got to be known and stated and worked with, has just increased, right? So that would be, you know, you'd have to be extreme. You can do practical things, say they're at a dosing center like we have here, what we call Rankin Court. If we know that the perpetrator is being dosed at the same place, we will transfer his dosing somewhere else. You know, all staff to be aware there's a current AVO. There is systems things you can do, absolutely. But it's really, when she's reported, an absolute, got to be a space of safety you know, and that's when your risk and your safety planning needs to increase. And you consult, if you've got social workers, consult with them as well, right? Yeah.
Yeah, I think, I think there's, you know, a lot to that. And
Yeah, there is. Yeah.
I imagine it's challenging, especially in the situations where there's mandatory reporting for
Yeah, absolutely.
childcare and those
Yeah,
things.
all that. Yeah.
But I guess it's reassuring to hear there are some police-based systems.
Yes, there is. There is. Yeah. There is. Yeah. But, you know, I mean, we're running out of time, and that's a whole different thing about police responses. Some are great, you know, and that's that thing, what I said. Sometimes there isn't the justice they think, you know. And I came across, just to give some encouragement around the police, and I don't mind naming him. He's the crime manager for one of the Sydney stations, which include King's Cross, Surrey Hills, Redfern and Day Street. And it's because I attend safety action meeting with the police, very high risk cases, for want of a better word. And this crime manager, because it was suggested that the woman had an extensive, what we would call, you know, drug and alcohol history, and that she was intoxicated that night. I love this. He said, I don't care how many drugs she took, what she took, he perpetrated violence, and I want him. I thought, can we replicate you 50 times over? You know what I mean?
Yep. Yeah.
So it is changing in the police, that they are getting better when you've got crime managers saying that's no excuse. Yeah.
Fantastic.
Yeah.
Well, look, there's obviously a lot more that we could talk about, and what was I going to say? But I'm afraid we have used up our hour.
Yeah.
So before I thank you for your time, I should just point out next week we have Dr. Jay Ramanathan and Dr. Una Nick Lonman on talking about cannabis hyperemesis management. So a big deviation away from this, but an interesting topic and something relevant, as I understand they're developing protocols down at Liverpool and Southwest Sydney on this issue. So, but here and now, thank you very much, Adele, for your time today and all of your insights. And thanks everyone for joining online. And I hope to catch you all next week. Thanks again, Adele.
Thank you. Thank you so much for the invite.
You're welcome.
Pleasure. Thank you. Bye. Bye.